and welcome to my channel. So we are going to be doing some anatomy high yield material, you could say, and let's get started with it. Okay, so first thing is when we see wrist drop, that is damage to the radial nerve. Excellent. Now the next one is claw hand, plus there is some sensory loss in the little finger and part of the ring finger. Now sensory loss is on the dorsum as well as the palmar side, so this is the medial side, right? So this is ulnar nerve damage. Next one is the ape hand. So basically the patient is going to present with paresthesia of thumb, index finger and middle finger. Alright, so this is 3.5 fingers on the lateral side. The nerve damage is median nerve. Right, and the next one is patient presenting with shoulder dislocation and there's difficulty lifting his arm, loss of sensation over the skin of deltoid muscle. Now this is the axillary nerve damage. The features of axillary nerve damage are weakness in the shoulder abduction, which is lifting the arm, and sensory loss or paresthesia over that area. And sometimes we also see wasting of the muscle, so basically flattening of the shoulder bulge, you could say, right? So that's axillary nerve damage. The next one is which nerve is damaged when there's humeral neck fracture. So neck of the humerus fracture or shoulder dislocation. Again, it is the axillary nerve damage. So it causes weakness in shoulder abduction and sensory loss over the deltoid area, or if it's a long-term problem, then there could be flattening of the deltoid as well. Next, we have humeral shaft fracture. Now, remember we have that radial groove going through the humeral shaft, so definitely radial nerve damage. And again, it's going to lead to wrist drop. Next, we have supracondylar fracture of the humerus. Supracondylar fracture would be median nerve damage because of basically the median nerve going through there, and there's anterior interosseous nerve, which is a branch of the median nerve that is going to get damaged specifically. So the features of median nerve damage are going to be seen here, which are sensory loss of lateral 3.5 digits. So lateral 3.5 is basically your thumb, index and middle finger, and half of the ring finger as well. Then next we have winging of scapula, very popular. Now winging of scapula is basically damage to the long thoracic nerve, and when you see drooping of the scapula, that's accessory nerve damage. But when you see winging of the scapula, that is long thoracic nerve damage. Excellent, you got that right. Now moving on to the next one. There's difficulty in knee extension and hip flexion. There's sensory loss in anterior and medial aspects of thigh and medial foot. So which nerve is most likely damaged? It's femoral nerve. Let's look at it again. When there's femoral nerve damage, sensory innervation of the medial thigh, medial side of the leg and foot are going to be affected because it's supplied by the spinous nerve, which is a branch of the femoral nerve. So there will be difficulty extension of knee and flexion of the hip. Sensory loss in anterior and medial aspects of the thigh and medial foot as well, leg and foot as well. Moving on to the next one. So there's a patient who underwent some surgery for varicose veins and now has numbness in the medial side of the thigh. This is medial, so it's saphenous nerve damage. Next we have most common nerve injury caused by femoral neck fracture or acetabular fracture. That is sciatic nerve because the sciatic nerve passes through there. Okay. Next we have the neck of fibula fracture. That is going to damage common peroneal nerve. Let's do that again. Neck of fibula fracture, common peroneal nerve damage. All right. Moving on, we have loss of lateral sensation in the lateral side of the foot. Loss of sensation, lateral side of foot, sural nerve damage. Okay, so medial foot, it's we're talking about leg and foot. Medial leg, saphenous nerve. Lateral foot or lateral leg, sural nerve. Okay, lateral is sural and medial is saphenous nerve of the leg. Then next we have foot drop. Think. So foot drop has two conditions. It could be because of a damage to the common peroneal nerve, which is when the common peroneal nerve is damaged, definitely the deep peroneal nerve would also be affected, and that's why we see foot drop. And that's the major cause. But sciatic nerve damage would also lead to foot drop. Alright? So if there is a sciatic nerve damage and it's accompanied by sensory and motor deficits above the knee level, that's definitely going to cause foot drop. Okay, moving on to the next. So there's a chronic disease that leads to glove and stocking pattern paresthesia. Excellent, that's diabetes mellitus. But that could also be because of vitamin B12 deficiency. So keep that in mind. But here we were talking about chronic disease. So disease is diabetes mellitus. Alright? Next we have most common nerve injury, where we have lateral injury to the lateral side of knee, and there's foot drop. We have already done this. So lateral side of the knee, common peroneal nerve, right? Excellent. Moving on, we have there's a fracture of the neck of fibula and leading to foot drop. We already talked about this, common peroneal nerve. All right. Next, we have some recent removal of below knee cost and foot drop. Again, common peroneal nerve. Great, you're doing great. Next, we have some patient who falls down a ladder and hits the shoulder and arm. And that leads to weakness of the right shoulder abduction, unable to external rotate, and there's also loss of sensation on the lateral side of the forearm and hand. So, there is going to be damage to either upper brachial plexus or injury to the nerve, axillary nerve palsy. What do you think? It's definitely upper brachial plexus. Why? Because we're also mentioning loss of sensation to the lateral side of the forearm and hand, right? Along with weakness of the right shoulder abduction and unable to rotate, right? Externally rotate. We're also talking about loss of sensation on the lateral side of the forearm and the hand. So Axillary nerve definitely does not leave the arm. It just gets, it just applies until the arm. When we're talking about anything beyond that, that's definitely going to be upper brachial plexus injury. Basically, it's going to be an injury of the trunk, upper trunk. All right. So while the axillary nerve palsy presented with the inability to abduct or externally rotate the shoulders, it will not cause loss of sensation in the lateral forearm and hand. Okay. So the next thing that we're going to be talking about should be. Okay, so basically there was another person who was cleaning the windows and grabs a ledge and kind of falls on the outstretched arm, right? And there's a fracture of the left elbow and injury to the left shoulder. Now, they present with loss of little finger and medial side of the ring finger, unable to cross ring and the medial finger, and unable to abduct middle finger, and there's no claw deformity. We're not talking about claw deformity, so it's definitely not going to be ulnar nerve, right? But there's problems with the ulnar side, so this should be the lower trunk brachial plexus injury. Okay. All right. Thank you, Miss Bunny. I appreciate everything that you did for us. So I'm going to take it from here. Thank you so much. So let's just continue with what Miss Bunny left us off with. Although it does show that she has a lot of expressions, like she mentioned that she is expressive, Bunny, but she's not. Honestly, I, being a sloth, have more expressions than her. Anyways, let's get on with this weird stuff, also known as high yield anatomy. All right. So she left off at inferior brachial plexus injury. So what are the symptoms of inferior brachial plexus injury? So the symptoms are basically there's going to be loss of sensation of the little finger and medial side of the ring finger as well, and the person is going to be unable to cross the ring finger and the medial finger and unable to abduct medial finger, but there's no claw hand. That means not ulnar nerve damage. It's going to be a lower trunk or inferior brachial plexus injury. Now this is going to be lower trunk. Let's recall, where does the lower trunk form from? Which nerve roots? Yes, that's right, C8 and T1. Let's recall for a second that the brachial plexus is basically made from C5 to T1. C5 and C6 unite to form the upper trunk, C7 continues as a medial trunk, and C8 and T1 form the lower trunk. Alright, so that's what we have here, injury to the lower trunk, or inferior brachial plexus injury. Alright, so this is usually when a person is falling down from a height and they fall on their outstretched hand. Now, moving on, again, if there is a C5 and C6 damage, so there's going to be numbness of the arm and numbness of the lateral forearm. So basically, that's going to be axillary nerve and musculocutaneous nerve damage. So that's upper trunk, upper brachial plexus, or upper trunk damage, right? Then again, if we have an ulnar palsy, ulnar nerve palsy, but it also has some features of weakness above that, that's going to be inferior brachial plexus injury. Now, moving on, which lymph node group is responsible for drainage of the ovaries and testes? Para-aortic lymph nodes. I know that was a jump from the upper limb to the ovaries and testes, but that's how high yield material is. Let's get on. So para-aortic lymph nodes drain the ovaries and testes. All right. Next we have scrotum and the vulva. Where do they get drained? Oh, the lymph nodes are basically superficial inguinal lymph nodes. All right. Superficial inguinal lymph nodes. Let's recall there's another thing that drains into the superficial inguinal lymph nodes. That's the lower part of the rectum, that's below the pectineal line, all right, pectinate line. Next, we have the posterior oropharynx lymphatic drainage. That's going to be the deep cervical or the jugular lymph nodes. Next, we have the medial malleolus. Now, what are we talking about? Which malleolus? The medial malleolus in the foot, right? Lower limb. So inguinal lymph nodes are going to be draining them. In a patient with a non-healing ulcer of the skin of the right medial malleolus, the inguinal lymph nodes are most likely involved, right? Next, let's talk about the eye nerves, eyes. Okay, all the muscles of the eye are innervated by third cranial nerve. That's the oculomotor nerve, except for two muscles. Now, two muscles are superior oblique that are supplied by the trochlear nerve, and lateral rectus that's supplied by the abducens nerve. All right. So, how do you remember third cranial nerve and all of these? So we just remember LR6 and SO4. SO4 like sulfate, right? So LR6 is lateral rectus 6, which is abducens nerve, and superior oblique SO4, superior oblique cranial nerve 4, which is the trochlear nerve. Then we have ptosis along with mydriasis. Ptosis along with mydriasis, and obviously some ocular problems. That's going to be third oculomotor nerve damage. Okay, third nerve. Because the cranial nerve 3, the oculomotor nerve, not just supplies the extraocular muscles, but it also supplies the ciliary epithelium, right? And it controls the pupil, basically. So it also supplies the muscles of the pupil, right? And controls the pupillary mydriasis. Pupillary constriction. So if there is a damage to that, it would lead to mydriasis, right? And oculomotor nerve. So basically, let's just quickly revise neuroanatomy here. So where would we see the nucleus of oculomotor nerve? Midbrain. Okay, so midbrain has like superior colliculi that are in the upper portion and inferior colliculi that are in the lower portion. So upper portion is going to have cranial nerve 3 nuclei, which are around the level of superior colliculi. And then let's come to the next one. At the level of the inferior colliculi, we're going to see the nuclei of the trochlear nerve, cranial nerve 4. Now, that was the midbrain. Superior colliculi, oculomotor or third nerve nuclei. And at the level of inferior colliculi in the midbrain, we have the fourth cranial nerve nuclei. And obviously above the midbrain in the diencephalon, you're going to see the cranial nerve 2, which is optic nerve, and then cranial nerve 1 is olfactory nuclei. Basically, olfactory tract is going to be right next to the lobes, right? So the olfactory tracts sit on top of the ethmoid bone, and then the olfactory nerves go through the perforations in the cribriform plate directly go to the nose. So basically the olfactory bulb, the roof of the nose is formed by the ethmoid bone, and that's exactly what is perforated. And so the ethmoid bone, or the cribriform plate of the ethmoid bone, which is perforated, that's where the olfactory nerves go through. All right, so that's all about that. And then obviously we have all the rest of the nerves down from trochlear nerve lower. That's going to be the pons, medulla, and so on. All right, moving on to high yield material again. Next, we have a patient with diplopia. When looking downstairs is trochlear or cranial nerve 4 damage. And basically, the buzzword here, double vision on walking downstairs or reading newspaper. So that's trochlear nerve damage, cranial nerve 4. So it supplies the superior oblique, and if the superior oblique is not working, so it's going to be diplopia when going down or looking downward. Diplopia looking towards same side. That's the cranial nerve 6, abducens nerve affected. So abducens nerve, actually remember LR6 and SO4. So LR6 is basically going to be the lateral rectus supplied by the cranial nerve 6. So there's cranial nerve 6 damage, which is the abducens nerve. Next, we have a patient with some visual problems. Upon examination, you find mydriasis, which is dilated pupils, ptosis, which is dropped eyelids, and down and outward eye. Down and outward eye. So it's cranial nerve 3, oculomotor nerve damage. Why? Because, see, there's mydriasis, so the pupil is dilated, that means something's not working. Second, there's ptosis, so basically, yes, let's also mention that the cranial nerve 3 also supplies the eyelid, the upper eyelid, so it closes and opens the eyelid, right? So that's also the cranial nerve 3, oculomotor nerve, and so basically the oculomotor nerve is responsible for pupillary constriction, eyelid elevation, and muscles, most muscles, like 4/6 of the muscle of the eye movement. So if there's mydriasis, ptosis, and down and out eye, that's oculomotor nerve damage. All right, next, two nerves. Which two nerves originate from the midbrain? Remember, I told you upper or superior colliculi 3 and inferior colliculi 4. So it's oculomotor nerve and trochlear nerve. Next, we have a patient who has injury to head around the right eye area. He's complaining of numbness and altered sensation over the right cheek, lower eyelid, and upper lip. Right cheek, lower eyelid, and upper lip. So it's around this region. Never mind. So it's infraorbital nerve damage, which is a branch of maxillary nerve, which itself is V2. So maxillary V2 is basically trigeminal. It's the second branch of trigeminal nerve. All right, so let's just recall. Trigeminal nerve is the cranial nerve 5. It has 3 sensory branches, V1, V2, and V3. V1 is ophthalmic division, V2 is maxillary division, and V3 is mandibular division. So right now we're talking about infraorbital nerve damage, which is a branch of V2, which is maxillary nerve. All right, so with this, let's also recall trigeminal nerve. So trigeminal nerve is a mixed nerve. So basically, it supplies muscles like motor supply and sensory supply. We just talked about the sensory supply, which is V1, V2, and V3. So basically, sensory supply is to the face. So anything above the eye and around the eye is ophthalmic, V1. Anything around the cheeks is maxillary division of the trigeminal nerve. So we're talking about sensory innervation, okay? And then anything about jaw or the lower area, that's V3, and basically that's going to be the mandibular division of the trigeminal nerve. So it's just like you put 3 fingers, the first one pointing towards your eye, second one pointing towards the cheek, and the third one pointing towards the chin. So V1, V2, and V3, and that's basically that area that supplies sensory innervation to that region. This is cranial nerve 5, all right? And then this cranial nerve 5, the trigeminal nerve, also supplies muscles of mastication, okay? Mastication is just, chewing. Like that. So muscles of mastication, again, let's just recall muscles of mastication. Basically, we have lateral and medial pterygoid, and we have the bacinator. That was another one. All right, next. Herpes zoster. Now, there's dermatomes that can get involved in herpes zoster. So if there is some lesion over maxillary branch of the trigeminal nerve, that's going to be the palate, right? And if it's around the eye, the lesions around the eye, that's going to be ophthalmic division of the trigeminal nerve. And usually herpes zoster hides in the herpes zoster virus, which causes chickenpox in the children and shingles in adults. That affects the dermatomes as well. And when it affects the dermatomes, it causes a lesion over that region. So when it affects the eye, herpes zoster ophthalmicus involves the V1, which is the ophthalmic branch of the trigeminal nerve, right? So that's that. And when it involves the palate, then it's maxillary division of the trigeminal nerve V2. Next, we have the muscle that's responsible for metacarpophalangeal and proximal interphalangeal movement. This is flexor digitorum superficialis. All right, muscle responsible for movement of MCP and PIP. That's flexor digitorum superficialis. Next, we have flexor digitorum profundus. So DIP is left. So dip is profundus, flexor digitorum profundus. Next, we have ptosis with mydriasis. Again, that's going to be the oculomotor nerve. All muscles except lateral rectus, which is LR6, and superior oblique, which is SO4, are supplied by the oculomotor nerve. So when you see mydriasis, that's definitely oculomotor nerve. There's also another lesion. There's also another problem called Horner syndrome. Basically, what happens is you would see the oculomotor nerve problems, plus there's going to be some decreased salivation as well. So that's sympathetic problems as well. When you see these, like mydriasis, ptosis, and anhidrosis, basically inability to sweat or loss of sweat, and also decreased salivation, that's Horner syndrome that affects the sympathetic chain. All right. That's different than oculomotor nerve damage. In oculomotor nerve damage, we don't see anhidrosis, which is inability to sweat or decreased salivation. We don't see that. We just see ptosis and mydriasis. All right, next we have reflexes. Okay, so for reflexes, we have 1, 2, buckle my shoe, 3, 4, shut the door, 5, 6, blah, blah, blah. So basically, 5, 6 is pick up the sticks. All right, how do you pick the sticks? So you bend your arm and pick them up, and then 7, 8, lay them straight. So that's basically 5, 6, pick up the sticks. The reflex that picks up the sticks, flexes the arm, is C5, C6. Okay, C5, C6, pick up the sticks, flex your arm, and C7, C8, lay them straight, straighten your arm, right? That's extension reflex. So biceps reflex is C5, C6, pick up the sticks, and triceps reflex is 7, 8, lay them straight. That's going to be C8 and C7 and C8, all right? Then we have brachioradialis reflex. Now this is a little bit different, but it's just like with the flexors, so it's going to be C6. Brachioradialis reflex, basically C6. All right, next we have triceps. We just talked about it, C7, C8. Now remember S1, S2, buckle my shoe. S3, S4, kick the door. S1, S2, buckle my shoe. How do you buckle your shoe? Shoe is next to the ankles, so ankle reflex is S1, S2. All right. Now when we talk about kick the door, let's just think about something that looks like a bent knee. L. The letter L is like a bent knee, so it should be L3, L4. Okay. Keep that in mind. It's not S3, S4. It's L3, L4. Kick the door. How do you kick the door? A bent knee is being straightened. Knee reflex. Excellent. You got that right. So S1, S2, ankle reflex, buckle my shoe. S1, S2, buckle my shoe, ankle reflex. L3, L4, kick the door, knee reflex. Next we have anal reflex, S2, S3, S4, anal reflex. All right, you just have to remember this one. There's no trick to remember it. S2, S3, S4, anal reflex. But one thing that you can remember is that in Hirschsprung's disease, the anal and the rectum mucosa, basically the nerve supply of the anus and the rectum is affected. So we don't have. So in Hirschsprung's disease, the rectum lacks nerve supply, innervation, and that's why there's a megacolon, right? That's a congenital problem. So S2, S3, S4 are basically the nerves that supply, or dermatomes that supply the rectum as well, all right? Rectal biopsy is the investigation of choice for Hirschsprung's disease to confirm the diagnosis. So anal reflex, S2, S3, S4. Anal reflex, S2, S3, S4, all right? Next we have chest drain. So best location for chest drain placement is 5th intercostal space, mid-axillary line. Place at the superior border of the rib to avoid injury to the van. What is van? Vein, artery, and nerve. Intercostal vein, artery, and nerve. The rib has its venous, arterial, and nerve supply just below it, so we need to go at the superior border of the ribs to prevent damage to those structures. So 5th intercostal space, mid-axillary line, right? And that's where we put the chest drain. And it should be at the superior border of the rib. Next, we have a patient who presents with a painful swollen knee after a fall. The pain is localized at the kneecap with overlying swelling. Which single anatomical structure is most likely affected? Now, there's a swelling and there's painful knee swelling at the kneecap. That is prepatellar bursa, also known as housemaid knee. So the prepatellar bursa is a frontal bursa of the knee joint above the patella. It's a superficial bursa with a thin synovial lining located between the skin and the patella. Next, we have the muscle responsible for flexing the distal phalanges of the 4 medial digits of the hand. That's flexor digitorum profundus. We just talked about it. The distal phalanges dip is flexed by the flexor digitorum profundus. Patient will have trouble gripping items if there's damage to the flexor digitorum profundus. Next, we have a patient who had a hand injury, unable to flex the proximal interphalangeal joint, PIP, and metacarpophalangeal joints, but can flex the distal interphalangeal joints. So this is flexor digitorum superficialis problem, damage to the flexor digitorum superficialis, because FDS is responsible for flexion of the PIP and MCP. All right, the flexor digitorum superficialis is responsible for flexion of the proximal interphalangeal joints and the metacarpophalangeal joints, whereas the distal interphalangeal joints is flexed by the flexor digitorum profundus, and Next, we have extensor digitorum. So when a patient is unable to extend the distal phalanx of ring finger, that's extensor digitorum, and extensor digitorum is responsible for extension of every joint on the medial forefinger. Now, when we talk about the medial in the hands, that's basically the little finger area, pinky finger. If a patient with a hand injury is unable to extend the metacarpophalangeal joints on the thumb, the muscle injured is extensor pollicis brevis. Okay, unable to extend metacarpophalangeal joint on the thumb. That's extensor pollicis brevis. So pollicis brevis is short thumb, and basically extensor pollicis brevis is responsible for metacarpophalangeal joint extension of the thumb. Now, what about the extensor pollicis longus then? That is responsible for the interphalangeal joint of the thumb. Recall that the thumb has only one joint in the middle, so it's just interphalangeal joint, and then the second joint is the metacarpophalangeal joint. So metacarpophalangeal joint extension is extensor pollicis brevis, and interphalangeal joint extension is extensor pollicis longus of the thumb. Now, what anatomical structure or landmark lies just above the midpoint of the inguinal ligament? That's the deep inguinal ring. Patient has complaints of decreased tongue movements after a mandibular gland excision. Tongue sensations are intact, but on protrusion, the tongue deviates to the right side. This is hypoglossal nerve, because hypoglossal nerve supplies the muscle of the tongue. But then again, on which side? Because we're saying the tongue deviates to the right side, so it's going to be the right hypoglossal nerve. All right, you have to remember that. Right hypoglossal nerve, right tongue deviation. Next, we have decreased taste sensation and decreased salivation following a tympanoplasty. Facial nerve damage. Next, we have nodes, so let's just talk about this. Which lymph node is most likely involved in a lesion or patch on the mid-third of the tongue? Submandibular lymph node. Next, we have upper limb damage. Patient was screwing a cover to the wall when he felt a rupture at the cubital fossa. Cubital fossa rupture, swollen elbow, and weak flexion. So basically, when you feel a mass after a fall, when you feel a mass at the cubital fossa, that's basically a bicep tendon. So this is biceps tendon rupture. We also call it Popoy's sign, so proximal bicep rupture, and distal bicep rupture is basically sharp pain in the cubital fossa. Underlying mechanism of dupuytrenal contracture. Formation of thickened fibrous tissue within the palmar fascia. That's going to be dupuytrenal contracture. And lateral aspect of leg. Nerve is the sural nerve, and the vein is short saphenous vein. Medial aspect of the leg. Nerve is the saphenous nerve, and vein is long saphenous vein. Or we can also call it the great saphenous vein. Then a man has had pain on his neck, which radiates to his left shoulder and down to the left middle finger. Which nerve root is most likely affected? Middle finger is always C7. Middle finger, always C7 dermatome. Next, we have, if a patient has lower back pain shooting down his leg after lifting heavy objects with intact ankle and knee reflexes, but reduced sensory stimulation on dorsum of the right foot, that's L5. So the sensation of dorsum foot is supplied by L5 and S1. S1 is responsible for the ankle jerk, and if it's intact, then this is only L5 which is damaged. All right? In a patient with lung cancer, with hoarseness of voice, what is the single most likely nerve damage causing hoarseness? Recurrent laryngeal nerve. Now, let's just think about another thing. So hoarseness of voice is recurrent laryngeal nerve damage, and inability to produce high-pitched sounds, that's damage to external laryngeal nerve, which is a branch of the recurrent laryngeal nerve. So most common case is total thyroidectomy 2 weeks prior, and that led to hoarseness of voice. So this is recurrent laryngeal nerve. Now, if it's a bilateral recurrent laryngeal nerve injury, then that's going to cause aphonia. Basically, the person cannot talk. Carpal tunnel syndrome, median nerve compressed, and cubital tunnel syndrome, ulnar nerve compressed. Which is the single most likely anatomical structure to be pierced when inserting a drain in the mid-axillary line? Most likely anatomical structure is going to be the intercostal muscles, but if it's fifth, then it's pectoral muscle, pectoralis major muscle. And that's about it.